Kramer. She received her MD from the Medical College of Pennsylvania in Philadelphia. She did her internal medicine residency and pulmonary critical care fellowship at Brown Medical School and is affiliated with hospitals in Providence, Rhode Island. Dr. Kramer is board certified in pulmonary diseases and critical care medicine. In 2002, she joined the respiratory medical group in Walnut Creek. And in the outpatient setting, she specializes in the treatment of chronic cough, asthma, COPD, bronchitis, bronchitis of sorts, I guess, and lung masses. She actively cares for patients admitted to John Muir in Walnut Creek with critical illnesses such as sepsis, respiratory failure, ARDS, and post-traumatic injuries. Currently, she's the medical director of the intensive critical care units of John Muir Medical Center in Walnut Creek. Dr. Kramer.
Thank you so much for that nice introduction. And I'm going to start by saying, if I happen to cough in the midst of this, I know I have a thoracic surgeon and, an oncologist here, and maybe I can consult myself, but I've had this little tickle for a while. Anyway, thank you all for coming out this afternoon to hear us speak. I'm going to be speaking with you a bit about risk factors for lung cancer and preventative strategies to kick us off. So by way of background, more than 170,000 new cases of lung cancer were diagnosed as of 2005, and that number has been increasing over time with over 160,000 deaths. The average age at the time of diagnosis is 60 to 80 years old, and tobacco use remains a strong associated risk factor, with 85% of patients diagnosed with lung cancer having been smokers. And unfortunately, early stage detection remains difficult and elusive. And just to speak to some of the sort of risk associated with lung cancer, in terms of comparison with colorectal cancer, breast, and prostate, all of which have robust screening tests, lung cancer is responsible for far more deaths than any of the three, which are much more popular in the public eye. And things to remember about lung cancer is that 75% of patients that present with a symptom have locally advanced or metastatic disease at the point of presentation. And so those symptoms might include cough, shortness of breath, coughing up of blood, repeated pneumonias in the same location, chest pain, fatigue, weight loss, or they may have no symptoms at all. And remember, most patients who present with any symptom already have advanced or locally locally advanced or metastatic disease. These are some numbers for a type of lung cancer called non-small cell cancer. And what's important to highlight here is the discrepancy in 5-year survival depending on stage. Patients who present with early stage or stage 1 lung cancer have a predicted 60 to 80% 5-year survival. However, that predicted survival drops significantly to less than 1% when diagnosed at stage 4. So the concern in the medical community is to find a way to diagnose lung cancer, which frequently is asymptomatic in early stages, at an earlier point in time, at which point interventions can be more helpful. So some risk factors associated with lung cancer. The largest risk factor that we are aware of and that is very popularly known is smoking and secondhand smoke. In the US, cigarette smoking is associated with about 90% of lung cancers. And we all know tobacco smoke is a toxic mix of more than 7,000 chemicals. People who smoke are 15 to 30 times more likely to get lung cancer or die from lung cancer than people who do not smoke. And the more years that a person smokes, and the more cigarettes smoked per day, we call that pack years in medical speak, the more the risk goes up. And every year in the United States, about 3,000 people who never smoked die from lung cancer associated with secondhand smoke. And an interesting side note, I spoke about lung disease in women a while back at a national meeting, and there's an increased risk associated with secondhand smoke exposure, particularly with women for various reasons. There's a dose response that is more dominant in women than it is in men, although both are at risk. So other things associated with lung cancer include exposures, either at home or in the workplace. And one thing that we don't hear too much in the popular press locally here, but we hear more about in other parts of the country, is radon exposure. So radon is a naturally occurring gas that comes from rocks and dirt and can get trapped in the ground below houses and buildings, and it can leach up into the buildings. It cannot be seen, tasted, or smelled, but according to the EPA, radon causes about 20,000 cases of lung cancer each year. And examples of other substances that might be found with regard to exposures include asbestos, arsenic, diesel exhaust, some forms of silica and chromium, and those are all industrial type exposures. The risk of getting lung cancer may be even higher in individuals exposed to those agents compared with those who smoke. Personal history is another potential risk factor. However, when we talk about risk of lung cancer within a family, it's hard to tease out whether it's true genetics or whether it's sharing similar habits like smoking, sharing a living space that might be exposed to high levels of radon, or other environmental problems. Those questions are still somewhat questionable, although we do associate personal history of lung cancer strongly with the development of lung cancer. Other risks include history of radiation to the chest. Cancer survivors who had radiation therapy to the chest are at higher risk of lung cancer. So, for example, patients who received radiation for Hodgkin's disease, or women who had breast cancer treated with radiation to the chest, might be at increased risk of subsequent secondary lung cancers later on. There are also some questionable dietary associations. It's not clear what those associations are. There's not a good solution in terms of what can I take to give me an anti-cancer diet, or what should I avoid. But interestingly, there have been some studies which have identified a risk of lung cancer in smokers who also supplement with beta-carotene. And there are other weaker associations that have been identified as well, but none that are very strong. I'm presenting this Environmental Protection Agency map to you to give you a sense of areas of heavy radon exposure. So the dark orange areas, particularly in the northern zone of the U.S., are areas that are higher risk with regard to radon exposure. And that has to do with the quality of the soil in the northern states compared to other states. The middle orange colors are zone 2, so slightly lower concentration, and then zone 3 is the lowest risk concentration. The Bay Area, most of it is zone 3. There may be some zone 2s in the area as well. And the EPA in general, in terms of radon screening, does recommend that there are methods for screening your home for radon, and we recommend that you look at the EPA website. There's a link to radon screening that you could use to connect. There are some home screening kits, but depending on the location and the type of soil, there are different recommendations. So that would be something to consider. So segueing from risk to prevention, when we discuss lung cancer prevention, one of the most important pieces of advice we have is that you don't smoke and avoid secondhand smoke as much as possible. Quitting tobacco will lower the risk of lung cancer regardless of age, regardless of the age that you are, regardless of the age at which you quit. And the longer a person goes without smoking, the more his or her risk will improve compared to those who continue to smoke. Risk in people who have quit is still higher than risk in people who never smoked. And other aspects of prevention include making your environment as safe as possible, screening for radon as recommended by the EPA, and also for those who are working in high-risk environments, wearing respirators or making sure that that those individuals get regular screening of their lungs as recommended by their workplace. So I wanted to speak a bit about screening for lung cancer. And until recently, we really did not have a very good option for screening regularly. And that situation has changed recently because of a very large body of research. And so when we talk about screening, sometimes it's hard for us to explain why we can't screen for a certain disease state, but we can screen for something else. So we start with a description of what screening is. Screening is subjecting an asymptomatic cohort of the population to a test with the hopes of identifying a disease process. And so it's important to identify risk factors, and the higher the risks, the more productive the screening. So the disease must have a treatment that is changed by earlier stage identification. And if the identified incidence is high, the population screened is too small, or the criteria to screen too restrictive. And so what's a good test? What's a good screening test? Disease must be detected in a preclinical phase, a phase where it may not be, where it's not obvious, where there are not symptoms such as coughing up blood, chest pain, and so forth in the case of lung cancer. It needs to be easily accessible to the population at risk. It can't be an expensive, high-level test that most people can't afford. It needs to be relatively easily accessible. There needs to be low risk associated with the test. We don't want to be doing tests that cause secondary harm to the population. There also needs to be an acceptable false negative and false positive rate to avoid misdiagnosis and avoid unnecessary additional testing and biopsies. There must be an effective treatment for the disease. If we identify it but we can't treat it, there's not much point in testing for it in the first place. The test must be cost effective. And some examples of good screening tests that have passed the test of time include mammography, colonoscopy, and pap smears. And so some brief words about the LCAP study, which is the International Early Lung Cancer Action Project, which was started all the way back in 1993 at Cornell. It was designed for a high-risk population for lung cancer, and they used low-dose, non-contrast CT scans, performed initial screening and then annual exams, and there have been multiple publications subsequently over the last several years as the data has been analyzed. So important highlights from this series of data include that the 10-year survival for all cancer patients detected in that study was 80%. There was a low rate of advanced and metastatic disease. And the 10-year survival for clinical stage 1 was 88% when all treatment options were considered. The 10-year survival for clinical stage 1 treated with surgical resection was 92%. And in a population at risk for lung cancer, screening, it was found, could prevent 80% of deaths from lung cancer. And all patients that did not receive treatment died within 5 years. So patients who elected for whatever reason, age, other comorbidities, or personal choice, who decided not to be treated, all of those patients died within 5 years. And so what's important with regard to thinking about screening for lung cancer in particular is patients who will be screened must be able to tolerate curative resection, because the idea is to identify cancer in its early stage. And surgical resection is still the best treatment of choice and most likely to give the best outcome. And so what we want to do is capture those cases early in stage, and surgical mortality must be acceptable, very low, at less than 1%. Complete pathologic staging is necessary, and we do that with lymph node sampling through different surgical techniques. And chemotherapy may be recommended pre or post-operatively as adjunctive therapy as well. And so some bits about this data, the rates of detection in this population was 1.3% at baseline, so for that baseline study, and 0.3% on annual subsequent CT scans. And if you were to start screening at the age of 60, baseline detection rises to 2.7%, with annual detection increasing to 0.6%. And just by point of reference, with breast cancer screening, you can detect 0.6 to 1% at baseline and 0.2 to 0.4% on annual mammograms for women over 40. So that's a nice comparison for you. It puts those numbers into perspective. The cost of these screening scans is approximately $375 to $400. And when you consider the overall cost savings of screening and surgery versus later stage treatments, in most cases, this will be a more cost-effective option. And so what are the current recommendations according to the United States Preventative Services Task Force on the basis of this data? The current recommendations for screening for lung cancer include annual low-dose CT scans for people who are current smokers or people who have quit within the last 15 years, aged 55 to 79 years old, who have a smoking history of 30 pack years or greater. When we say pack years, we mean number of packs smoked per day multiplied by the number years that a person has smoked. So that means if I smoke 1 pack per day for 10 years, I have a history of 10 pack years of smoking. Informed decision making is required regarding the possible cumulative effects of CT scans and the potential downsides of a false positive scan, which include sampling of benign nodules. So this raises a concern that frequently comes up in my practice because we use CT scans both for screening high-risk populations, but also for following patients who've either had a lung cancer treated or who have an undiagnosed lung nodule, which we want to follow with time. And I frequently get asked, well, what about the risk of CT scanning over time? And so that's a difficult question to answer, and I think there will be subsequent data that helps us understand the answer to that question better. However, this is what we know at this point. Radiation dose is dependent on how much radiation is received over a lifetime cumulative dose. And it's also dependent on whether low or high dose CT scans were used. And with the screening population, we talk about using low dose CT scans. A single CT scan subjects the human body to between 150 and 1,100 times the radiation of a conventional X-ray, or around a year's worth of exposure to radiation from both natural and artificial sources in the environment. Concerns obviously include the development of secondary cancers after a prolonged latent period. And so what's been popular in the popular press lately is extrapolated data from what's known historically about survivors of nuclear explosions during World War II. So National Cancer Institute estimates that 29,000 future cancer cases could be attributed to the 72 million CT scans performed in the country in 2007. And that increase is equivalent to about 2% of the total 1.7 million cancers diagnosed nationwide. And a 2009 study of medical centers in the San Francisco Bay Area also calculated an elevated increased risk of 1 extra case of cancer for every 400 to 2,000 routine chest CT exams. Most estimates, however, of the excess cancer risk from CT scans over the past several decades rely largely on a potentially misleading set of data, which includes cancer rates among the longest long-term survivors of atomic bomb blasts in World War II. And for many reasons, there are problems associated with extrapolating that data. For example, there's no standardization for exposure. How close was someone to the blast? How much radiation did they actually receive? Or for other risk factors, other medical problems that those patients had, for example, underlying malignancy, underlying radiation to the chest at some point in time, whether it was partial or whole body exposure. When we talk about CAT scans, we're talking about a limited dose exposure to one part of the body as opposed to the whole body. And in addition, the current general population has better access to health care and better nutrition than the population at that time. So studies will actually be emerging concerning the true risk associated with CT scans, and that the jury is still out there. Until then, use of low-dose CT scans, when possible, is recommended in the high-risk population which I described to you. And this is a risk-benefit kind of thing. Theoretically, an associated secondary malignancy may not occur for decades following exposure. And so if we're screening that high-risk population, if we screen a patient who's 70 years old and they have a theoretical risk, we don't even know if it's a real risk, of developing a secondary malignancy, 20, 30 years down the road, that risk becomes less important or less significant. So I'd like to stop there and thank you, and we'll be taking questions as we said at the end.